With over 43 million Americans suffering from arthritis, hip replacement is not an uncommon procedure. According to the Academy of Orthopedic Surgeons, hundreds of thousands of hip replacement surgeries are done each year in the United States. Chances are you are considering this operation because you have chronic pain from hip arthritis that causes significant limitations in your everyday activities. The goal of this program is to help you understand your treatment options and to educate you about hip replacement surgery. It will provide you with information about what to typically expect before, during, and after hip replacement surgery, and show you how you may be able to have less pain and live a more active lifestyle. During this presentation, we will discuss the following topics: anatomy and arthritis, treatment options, how to know if you are a candidate, preparations for surgery, risks and potential complications, the surgical procedure for total hip replacement, and what to typically expect after your surgery. Please review this information with family and friends and write down any questions you may have. And as always, please talk to your doctor if you have any questions or concerns. As a ball and socket joint, the normal hip is capable of a wide range of motion. A rounded ball of bone at one end of the thigh bone, or femur, moves or articulates inside a cup-like socket that is part of the pelvis. Articular cartilage, which is smooth and firm, lines the socket and covers the ball. Normal cartilage allows the ball to articulate or glide smoothly within the socket to give you full motion of the hip and movement without pain. Arthritis is a condition where the cartilage lining the hip joint wears out. The joint no longer moves smoothly without pain and discomfort. Mobility is usually affected as well. Patients with arthritis of the hip experience pain, particularly with activities such as walking, stair climbing, arising from the seated position, and prolonged standing. They also have difficulty with athletic activities involving quick changes in direction, and moving beyond a limited range of motion causes pain. The most common form of arthritis of the hip is degenerative or osteoarthritis. Trauma to the hip joint, such as fracture of the ball or socket, rheumatoid disease, or other types of systemic arthritis, can lead to breakdown of the articular cartilage and degeneration of the hip joint. A sensation of grinding and popping can occur in the hip joint when the articular cartilage is worn, either partly or completely. One bone rubbing directly against the other produces pain. The first X-ray shows the normal ball and socket of the hip joint. There is a wide space between the ball and the socket, which is occupied by articular cartilage. This is a normal joint space. In the second X-ray, the ball is rubbing directly against bone. The space for the articular cartilage has been eliminated, and the bones are in direct contact with each other because the articular cartilage is completely worn away. Moderating and modifying activity are important for reducing the symptoms of arthritis. This may mean walking less, particularly if you walk for exercise, and walking for a long time significantly increases your discomfort. It may also mean avoiding stairs. Certainly, you should avoid athletic pursuits that cause pain, such as running and court sports involving directional changes, which can cause significant discomfort. Although you may have to modify your activities, it is important to keep moving the arthritic joint to maintain range of motion and strength. Your doctor may prescribe formal physical therapy instruction. You can also use an exercise bicycle with a high seat position and little resistance. A water exercise program is an excellent way to build strength and gain motion while avoiding weight bearing across the painful arthritic hip. Some people benefit from the use of heat, although it is often not effective because the heat cannot penetrate to the hip, which is a very deep-seated joint. Ice may also be tried, although many people find it uncomfortable. External support, such as a cane or crutch, in the hand opposite the arthritic hip can be helpful for walking, as it shifts the weight from the arthritic hip to the uninvolved hip. Along with these measures, oral medication can be of benefit. This medication usually begins with over-the-counter or non-prescription medications, including acetaminophen, ibuprofen, or naproxen. Once this medication is not effective in controlling discomfort, your doctor may prescribe non-steroidal medications. The use of nutraceuticals such as glucosamine and chondroitin sulfate may also be beneficial in moderate to severe osteoarthritis. Another treatment option is injection of cortisone into the arthritic hip joint to help decrease inflammation and therefore decrease pain. This measure, which can be employed several times a year, is temporary. How well it works and how long the effects last are unpredictable. Sometimes these injections require the use of a fluoroscope, which uses X-rays to create a moving image on a monitor so the doctor can make sure the needle is in the right place before injecting the medication. Arthritic disease of the hip is usually progressive. That is, it gets worse over time. Progression may not show on X-rays, but rather by increasing pain and incapacitation. Occasionally, X-rays may show a dramatic progression of arthritis, with substantial destruction of bone about the hip. In some instances, this can occur in a relatively short period of time. The measures just described are designed to allow an individual to live with an arthritic hip. If these measures become ineffective, you and your doctor may consider hip joint replacement. If you and your doctor decide that total hip joint replacement would be advantageous, you should fully understand the risks and benefits associated with the procedure. An artificial hip joint replaces your natural hip joint with one made of metal and plastic or ceramic that is pressed or cemented into place. The goal is to relieve pain and improve motion and function. Artificial joints can be very successful in achieving these goals. The question patients most frequently ask is, how long will the replacement last? The duration of an implant varies, depending on your age, activity level, and many other factors. The more demand that is placed on the artificial joint, the greater the potential for wear and failure over time. Longevity may also be dependent on the type of material used for the artificial joint. There is certainly no consensus as to the best material for the articular surfaces placed in a hip joint. The best choice may depend on the age of the patient and the demand to be placed on the material. Talk to your doctor about the implant options that are best for you. With your new hip joint replacement, it is okay to walk, bike, golf, and play doubles tennis. Ultimately, someone who chooses to undergo hip joint replacement will have to accept some limits in physical activity. It is important to talk to your surgeon about your desires and anticipated demands before considering this procedure. Before your surgery, you will spend ample time with your doctor and the doctor's staff learning about normal and arthritic hip anatomy and discussing your specific hip problem. Your doctor will thoroughly examine your hip and offer you adequate time to ask questions about the surgical procedure, rehabilitation options, recovery time, and special needs you may have before and after surgery. It is important that you address any concerns you might have with your doctor before hip replacement. It is also important to discuss which of a number of possible surgical approaches your surgeon will be using for your operation. And it is important that your questions be answered before your surgery and that you have a thorough understanding of both the operation and potential risks and complications. Preparing for a hip replacement begins weeks before the actual surgery date. In general, your doctor may discuss the following with you. Autologous blood donation. While some total joint procedures do not require a blood transfusion, it is possible that you may need blood during or after surgery. You can donate your own blood before surgery. Dental examination. Dental procedures such as extractions and periodontal work should be completed before hip replacement surgery to reduce the potential for infection. Medications. Your doctor can advise you which over-the-counter and prescription medications should not be taken before surgery. Stop smoking, to help reduce the risk of postoperative lung problems and improve healing. Lose weight. In patients who are overweight, losing weight will help reduce stress on the new joint. Laboratory tests. Blood test, urine test, an EKG or cardiogram, and chest X-ray may be prescribed to confirm that you are fit for surgery. It is important to be in the best possible overall health to help promote the best possible surgical experience. Here are some exercises that your doctor may recommend. Low-impact aerobic exercise. Swimming and riding a stationary bike are great low-impact exercises that help build strength. Stop any exercise that causes increasing pain. Short arc knee extensions. Roll up several towels in a roll 6 to 8 inches thick. Lay in bed with the towels under one knee. Bend the other knee. Keeping your knee on the towels, lift your foot to straighten the knee. Hold for a few seconds and lower the foot. Ankle pumps. While lying in bed, point your toes downward and then bring your toes back up towards your head, tightening your calf. Heel slides. Slide your heel along the bed, pulling your foot toward you as your knee bends. Straight leg raise. Start by tightening your quadriceps, the muscles in the front of your thigh. Then, with toes toward the ceiling, lift your leg 6 to 12 inches from the bed. Quadriceps sets. Lie on your back, legs straight. Tighten the muscle in the front of your thigh as you press the back of your knee toward the bed. Hold for a few seconds, then relax the leg. Standing knee bends. Stand while holding on to a steady surface, such as a table. Bend your knee as far as it will go comfortably. Hold for a few seconds and lower the leg. Increasing upper body strength is also important because of the need to use a walker or crutches after surgery. Bicep curls. In a sitting position, keep your elbow close to your body and your wrist straight. Bend your arm, moving your hand up to your shoulder, then lower slowly. Triceps extensions. Sit, leaning forward from the waist. Bend your elbow so that your forearm is parallel to the floor. Then straighten your elbow as you extend your arm behind you. Seated press-ups. Sit in a sturdy chair with armrests. With palms on the armrests, press down to lift yourself from the chair. Hold for 3 to 5 seconds. Bend your elbows slowly to ease back down. Talk to your doctor before starting any exercise program, and remember to call your doctor if you experience increased pain or swelling after exercise. Hip replacement helps hundreds of thousands of Americans each year to relieve their hip pain and get back to enjoying everyday activities. As with any surgical procedure, there are defined inherent risks that you should be aware of. Medical risks of hip joint replacement include infection, which can occur in the days or weeks after surgery. Infection can also occur at any time during the life of the artificial hip replacement if bacteria migrate to the joint through the bloodstream from another part of your body. It is recommended that you take preventive antibiotics after your operation for routine procedures such as dental work. Your doctor will let you know how long you need to keep taking them. It is important to follow these instructions. Infection of the hip after artificial hip joint replacement almost always requires additional surgery and prolonged use of intravenous antibiotics. Other medical risks of hip replacement surgery include blood clots involving the leg or lungs, complications from anesthesia, nerve or blood vessel injury to surrounding tissues, failure or delay of wound healing with loss of skin. A hip with multiple scars in previous operations is particularly at risk. Postoperative bleeding, possibly requiring blood transfusion. Heart attack. Stroke. Other problems may occur with the implanted joint itself over the life of the patient or lifetime of the implant. Although infrequent, these problems can occur and include implant loosening, thigh pain, especially in uncemented hips, dislocation, breaking or wearing out of the implant itself, reaction of the body to particles wearing off the implant, persistent restriction of motion, fracture around the implant following a fall, formation of extra bone around the artificial hip, unequal leg lengths. Unequal leg lengths after surgery are not uncommon. Despite careful measurement and assembly of the hip joint replacement, the diameters or lengths of the implant must often be modified to achieve a truly stable hip and to avoid or reduce the risk of dislocation. Initially, after hip joint replacement, a person may sense that their legs are different lengths, when they are in fact the same. This is the result of tightness around the joint and hip musculature. This goes away in the months after surgery. If leg length inequality is a persisting long-term issue, a shoe lift may be required. Before, during, and after surgery, your physicians and other medical professionals will take many steps to avoid any complications, performing various tests to ensure you can safely tolerate surgery. For example, you will be given a medication to thin your blood. This medication, either in oral or injectable form, helps to reduce the risk of a blood clot. You may need to take this medication for up to 2 or 3 weeks after the surgery. After your surgery, you may also have devices that compress your legs or feet to further reduce the risk of a blood clot. During and after your surgery, you will be given several doses of antibiotics to reduce the risk of infection. To begin the surgery, your physician will make an incision in the skin over your hip joint, cutting through the skin, soft tissue, and muscle to access the hip. Once the hip is reached, the ball is dislocated from the socket and removed from the end of the femur with a saw. The socket, or acetabulum, is exposed. After measuring the size of the socket to guide accurate selection, the appropriate reamer, a cheese grater type device, is used to create a perfect hemispherical bone socket that matches the external shape of the acetabular cup. The cup is carefully positioned in the bony socket. This cup is held in place using a number of methods, depending upon surgeon preference and your bone quality. These methods may include bone cement to hold the cup in place. Most cups are designed to allow bone to grow into the metal surface to hold the cup in place. These cups have a roughened or specially prepared surface, which is designed to allow ingrowth of bone into the metal itself. This type of fixation may be augmented by screws to help fix the cup in place while bone growth takes place. The inside of the femur, or thigh bone, is then cleared with various types of devices, and a prosthesis is placed into the femur. A trial ball is placed on the top of the femoral stem, and a plastic insert is placed into the cup. The hip joint is then articulated by placing the ball in the artificial socket. The hip is evaluated for the type and amount of motion it has and the stability of the joint. That is, the inability of the ball to dislocate from the socket easily. Once the appropriate combination has been found, the ball is then placed onto the femoral stem and the final insert is placed into the cup. The leg is evaluated again for stability and mobility and leg length equality. Throughout the operation, numerous measurements and operative considerations are taken to equalize leg lengths. However, the primary goal is to achieve a stable, non-dislocating hip. Prior to final assembly of the total hip, leg lengths are again evaluated. The new implants will replicate your hip joint. Your physician will rinse out debris from the hip joint with sterile fluid and then close the wound in layers with stitches and/or staples. A plastic drain may be placed in your hip and removed later. The purpose of the drain is to remove blood from the inside of the joint and tissues that might accumulate in the area after surgery. When you awaken from surgery, you will be in the recovery room. Pain management after surgery is an important part of your operation, and often one of the greatest concerns for patients. Your doctor will have talked to you about this before your operation. Pain management after surgery may be achieved by a variety of techniques, including type of anesthesia, patient-controlled injection of medication into their IV, and oral medication. After surgery, your physical therapist will show you how to properly get out of bed and begin walking with your walker or crutches. Your physical therapist will also teach you how to safely move with respect to your new hip, using the precautions directed by your surgeon based on the approach used to construct your hip joint replacement and the type and size of implants placed in your hip. Physical and/or occupational therapists will also teach you how to safely negotiate stairs and how to get in and out of a car during the first few weeks after surgery. You will start post-operative therapy almost immediately, gradually moving from passive to active exercises, which will strengthen your hip. Your physical therapist will work with you on post-operative exercises, many of which will be the same as the pre-operative exercises in this program. Also, instruction in activities of daily living, such as showering and toilet usage, will be provided. Precautions taken to avoid dislocation vary depending on the surgical approach used to install the hip joint and the stability of your hip at the completion of surgery. These precautions will be individualized for you. You will be in the hospital 3 to 4 days. This may vary based on your progress. Your doctor and physical therapist will establish discharge goals, and once these goals are met, you will be discharged. Rehabilitation will continue either at your home, an outpatient facility, or in a rehabilitation facility. A word about airport security. Since your implant is made of metal, it will almost always set off the metal detector at airport security. In the era of heightened surveillance, almost all security checks no longer accept a document that states that you have a metal implant in place. You should inform the screener that you have in place an artificial hip, and be prepared to be evaluated with a handheld detector. I hope we've answered most of your questions regarding hip replacement surgery. One last point. The success rate of this operation approaches 95%, so making the decision to proceed with the surgery may give you many years of pain-free activity, and perhaps even a new lease on life. And again, if you have any questions or comments, please don't hesitate to ask your doctor.
The core material of the program that you have just viewed is up-to-date and accurate. The Houston Clinic Joint Replacement Service has developed best practice protocols over the past 35 years. There may be some specific variations to these protocols that are based on surgeon preference, and if you have any questions about these variations or the program that you have just seen, then please discuss it with your surgeon and their staff. We hope that this educational material has helped you in making your decision regarding your treatment. Should you opt for joint replacement, the Houston Joint Replacement Service will do everything that we can to make your operation a complete success.